Today I'll discuss maintenance strategies or plans and kind of how I approach that when it comes to orthopedics. I think many, if not most people, tend to think of orthopedics as the domain of acute traumas, right? You trip and sprain your ankle, you got hit in a football or soccer game and hurt a ligament in your knee, or you fell and hurt your shoulder. And yes, acute or clear, memorable events that vary in amount of trauma do happen, but the average orthopedic injury is not that. The one that we see the most is things that happen maybe when someone took a long car ride or airplane ride, or rolled over in bed and noticed a jolt of pain in their back, or bent over to pick up something relatively benign and felt a strain in their shoulder or their neck or their elbow. So maintenance strategies for the people who have acute events, the fall, the car crash, the sports trauma that's either contact or non-contact, a maintenance strategy for them might be clearly don't have another trauma. And if there are things that we can do to mitigate the likelihood of that, then we can implement those. So we don't really think of maintenance for those types of injuries. Although if you're falling because you have poor balance or falling because you have a vestibular or an eyesight issue, again, attacking those root causes makes sense. Getting hit in a soccer game from the side of your body by another player is something we can't really control if you're going to continue playing soccer, for example, but we can control how your joints and muscles are moving. So a maintenance strategy for that might be, let's ensure you have good strength, mobility, proprioception, etc. When we think about the typical orthopedic problem though, the ones that I mentioned that occur without trauma or an acute event, maintenance strategies can be a little bit more prescribed, a little bit more concise. When we think of people who have a problem because they don't sleep, let's say they sleep 3 hours a night, and we fix their root cause problem by adjusting their sleep and other things as needed, and then that person's curious about how to maintain good health going forward that has been achieved with the treatment, I don't think of it as a maintenance program to say you need to sleep 6 or 7 or 8 hours per night. I think of that as teaching the patient what normal healthy patterns look like. I don't think it's maintenance to say you need to avoid your old ways of 3 hours a night of sleeping and get 7. But some people may consider that maintenance. I would say it's reinstilling normal lifestyle healthy habits or patterns. And the same thing goes for a lot of orthopedic injuries that I see. At least 70 to 80% of orthopedic problems that I see have to do with joint imbalances, mechanical problems in joints that create local or referred symptoms. They can create muscle weakness, nerve tension, changes in proprioception or sensation, but they're fixed by restoring normal joint mechanics, typically moving in just one direction to restore the joint to normal, but sometimes 1 or 2, or in rare cases even 3. But they're restored by moving repeatedly into the direction that gets the joint moving well again and resolving all signs and symptoms. So maintenance strategies for those types of patients, let's say it's a low back. Well, maybe the person got into this predicament because we can hypothesize that the person sits in a low back flexed posture for 10 hours a day and never does any concerted effort to move into full end range extension. So never getting on the floor and doing, an upward dog or cobra or something in a yoga class, never being on the floor on his or her stomach, never bending all the way backwards and standing. And most people don't do these things. These are not things that we're taught, of course. I think most people need to do these on a semi-regular or regular basis to maintain normal joint balance in this day and age when we're so often sitting in flexed postures. But nonetheless, if someone we think got into this predicament because of lifestyle habits of always being in a lot of flexion, or being in a lot of flexion at least 10 or 8 hours per day and never extending, then a maintenance strategy for this person could look like one of several things, or more than one of several things. We could reduce the amount of flexion through the low back. We could keep that amount of low flexion in the low back, and add extension, or we could say every day you're going to do this amount of extension, or every time you notice that you're sitting and you lose a little bit of mobility in your low back, we're going to do extension. It really is individual to the patient. For people who like to go to the gym and they do a lot of flexion-based activities in the gym, maybe they're doing Peloton and maybe they're doing sit-ups and squats, which are all flexion of the low back. Maybe a maintenance strategy for that particular person is keeping up those exercises like we want, but getting on the floor and doing some low back extension afterwards, or doing it in standing, whichever is most beneficial for that particular patient. So maintenance, we can think of it as doing something different in your life, of course, but we can also look at it through the lens of, well, if normal lifestyle habits include a variety of movements through our spine and our joints, and you've lost that variety, then we are just reintegrating that variety. And I would agree that it's not natural for people to make a very pointed effort to get on the floor and do low back extension, or get up against the kitchen counter and do low back extension. I would argue that historically we tended to get more low back variability in movements throughout our day by not as much bent, slouched, or flexed sitting throughout the day, especially sustained for hours, and 2, more varied movements like reaching, jogging, running, walking, that put the joints of the low back into a neutral or extended posture. So that could also be how someone mitigates the incidence of recurrence, not necessarily going to full end range extension with low back extension, but maybe incorporating more walking throughout the day by interrupting sustained sitting. For most people, sustained sitting is a decent amount of low back flexion at L5-S1. And for people who slouch in sitting or round their low backs, then we can get a significant amount of flexion throughout the spine and throughout the joints of the low back or the lumbar spine. So I want people to know when we get to discharge that finding a maintenance strategy that works for that patient is individual, and I can hypothesize as to what that patient will do well with, but it's ultimately me giving the education about how the patient can find out or figure out through trial and error what makes most sense for them. Is it changing the sitting? Is it changing how much you lie on your stomach to relax? Is it changing the order of things you do at the gym? The ultimate goal, of course, is to keep low back mobility full and pain-free. If it's a mechanical disorder, then pain-free, full mobility of the joint is what's going to ensure that it's mechanically staying stable. We don't have to wait for symptoms to arise. We can monitor signs. We can monitor the check engine light, as I like to say. So for me, I know what my normal full mobility of my low back is. I should be able to touch the floor with my fingers. I have a decent average amount of extension in standing. I have many patients who have above average, and when we show that through repeated movement testing, I want them to know this is your normal amount of range of motion. You probably thought it was 30 degrees less, but this is your normal. If you could palm the floor 5 years ago and you can't now, I'm arguing that we need to investigate. It's not because you're 5 years older, it's because something has happened, usually mechanically, but not always. There are other disorders of the spine and the low back, of course, but we need to maintain full pain-free range of motion. And if we're losing motion, we can use that as a sign that we are not using the best maintenance strategies. But this also speaks to the fact that if you understand the concepts of joint mobility and something goes awry, you get a stiff, achy back, or your neck locks up and you get some pain, you should have the tools, if we work together, to understand how to self-assess and self-treat in the large majority of these cases, because they tend to recur, but they're not going to be as severe, and they're usually, like I said, self-treatable. So that's really important to know as a part of the maintenance prevention strategy, is that these things tend to recur, mechanical problems tend to recur, usually because of lifestyle factors, not because you tripped off a curb again or you got in another car accident, but because something in your lifestyle is predisposing you to a joint imbalance. Things get tweaked all the time, but you can self-treat. And so taking away that fear from patients is really paramount, because they'll know that, oh yeah, these things happen. It's kind of like a cold. I don't have to go pay for more doctor's visits. I don't have to be anxious and fearful about this injury. I know what's going on. And like I said, in most cases, people can self-assess and self-treat. Typically, the directional preference that helped the joint before will help it again this time. So maintenance, understanding the maintenance and prevention program for these mechanical disorders is really understanding that these things are common. If we can pinpoint a lifestyle factor, let's try to fix that. If it's not due to lifestyle in terms of movement, maybe it's due to lifestyle in terms of inflammatory mediators that kind of keep problems around when they should be subsiding. Inflammatory reactions to joint disorders or other disorders should be transient and effective, and we don't want that inflammatory cascade to last longer and maybe become the dominant factor in someone's orthopedic disorder, making it more an inflammatory disorder on top of an orthopedic disorder. So we have to try to think of what these lifestyle factors are so that we can mitigate them going forward. Again, if someone falls and hurts themselves in their low back, but we notice that even though the prevention strategy would be not to fall again, we notice that, oh, if you do sit for long periods of time, you tend to get a little bit stiff, then addressing those lifestyle factors like positions and sitting can be helpful. Tendinopathies, things that occur because you had a weekend of, moving into a new apartment and putting together furniture, and you're twisting screwdrivers and doing all this stuff with your tendons on your elbow that you're not used to, and you get a tendinopathy. Well, we are curious about underlying causes because, of course, not everybody who does these things gets tendinopathies. So we might find an underlying cause that predisposes you to tendinopathy that can be understood as part of your maintenance. But for many people, it's just you fix the tendinopathy and you understand that, going forward, a maintenance strategy might be not to put so much pressure or so much load on a tendon at one time if you haven't exercised it in the past. But these things happen, so they're not something we really need to worry too much about long term. I think a big difference in how I approach orthopedic disorders versus other clinicians is that I do argue that 70 to 80% of orthopedic disorders are mechanical problems with joints. And therefore, because of that fact, there is a maintenance piece that we can address. If you just think that orthopedics is ligament sprains, muscle pulls, tendinopathies, fractures, things that are not as intertwined with lifestyle factors and more linked to sudden, acute, recent events, then you're not going to really belabor the point of maintenance. But I do belabor that point a lot. I think it's really key, especially for reducing that anxiety and fear and misunderstanding of what's happening to the body. Because if you understand joints get tweaked, oh, maybe my knee is hurting because, I was driving a lot and so my knee was in sustained flexion for 20 hours over the last 3 days. So maybe I need to push it into a little extension and take care of it myself. When that's someone's mindset, it's so different than my knee is hurting. I have no idea why. I need to seek medical attention, which is going to take time away from my job or from my family. It's going to, cost money. It's going to make me worried about the future of my knee. If you can understand that, well, maybe this is mechanical. Maybe my knee was flexed a lot more than it usually is, or maybe my hip was in a different position in this new seat at work. Those types of thought processes are not really common in orthopedics, but I want people to really start to think joints get tweaked a lot. And Robin McKenzie figured this out, over 50 years ago. And he noted that if that's the case, then there's a direction or two that will get it back on track. And so when we're not thinking about all these other tissue issues, we can start to think, oh, it's mechanical. Something got a little, mechanically involved. It's not moving quite right. Maybe it was this lifestyle factor that contributed. So maybe I should try this as a mitigation strategy or try to reduce that lifestyle factor, such as knee flexion, whatever the case may be. So for my patients, I really want to impart an understanding of how to maintain good joint health or tendon health or ligament health going forward. And at the crux of that is understanding that many of these processes, or most of these disorders in my book, are due to cumulative effects over months, years or even decades in some cases of lifestyle factors. And so if a lifestyle factor is what got someone into the mess, then somehow changing factors in the lifestyle going forward is what we need to do for prevention of major problems going forward, but understanding that minor things will likely reoccur at some point, but maintaining the ability to function normally and pain-free in most situations without fear or anxiety about orthopedics.